Ma'am, we are live now. Kindly let me
Okay,
know
you can
when
start
can
the
we start.
PPT. Yeah,
Yes,
you can
ma'am.
start.
Thank you.
I'll start, ma'am.
Yes,
Yeah,
sure.
ma'am. Please start.
A very good evening to one and all present here at the MAHAIP Postgraduate Case Forum. I'm Dr. Madhavi Ingle, and on behalf of MAHAIP 2026, it gives me an immense pleasure to extend a warm welcome to our respected President, sir, our respected Secretary, ma'am, our scientific convener, our advisors, and all our esteemed pediatricians, postgraduate residents, and of course, our experts. The academic session and this forum is specially designed for our postgraduates. As beautifully said in Sanskrit, Nasti Vidya Samo Bandhur, Nasti Vidya Samam Surut, Nasti Vidya Samam Vittam, Nasti Vidya Samam Sukham. Arthat, there is no friend, no companion, no wealth, and no joy as great as Vidya, that is knowledge. With this thought, MAHAIP 2026 proudly continues its strong academic tradition and commitment to nurturing our young pediatric minds through this PG Case Forum.
नाही
We are
पेशंट नाही बघ
fortunate to
ते
have
माझ्या कानातलं
Dr.
तिथं आलेलं आहे
We are fortunate to have Dr. Deepa Firke ma'am and Dr. Rajesh Kulkarni sir, our National IIP Executive Board members, as our advisors, and Dr. Sanjay Nathu and myself are the coordinators for this academic activity. Today, in our second academic session of 2026, we come together to enhance the clinical insight through an interesting case discussion of the renal system in the esteemed presence of our experts in the field. Before we begin the scientific session, I would request our respected President, Dr. Sanjeev Joshi sir, to kindly address the gathering. Over to you, sir.
So very good evening to one and all. At the outset, I welcome the experts for today's session, Dr. Manish, Dr. Sathe, our mentor, Dr. Shah sir, and I wish all the luck to the presenter, Dr. Supriya. Of course, uh, our team of PG Forum, Dr. Sanjay, Madhi ma'am, Rajesh, Deepa, you are doing an excellent job. Actually, on the very day I was thinking about the presidential action plan, the first and foremost thing which clicked into my mind was the PG teaching. Since I'm blessed, my team is blessed with the eminent faculties from the prestigious medical institute from all over the state. I thought that why not to utilize their expertise for empowering our PGs. And I'm really proud of all my team of Forum for doing an excellent job. And I also welcome my ever dynamic secretary, Dr. Renu. She's she's acting like a catalyst between different groups and all, and doing her job very nicely. So over to you, Dr. Madhavi. I wish the presenter a great luck, and I also welcome all the PG students who are attending this session and enjoy learning. Thank you so much.
Thank you very much, sir, for your encouraging words. May I now please request our dynamic, versatile Secretary Ma'am, Dr. Renu Borelkar Madam, who has always been a driving force for all of us to work together for the best possible things in the IIP. Please, ma'am, over to you.
Yeah, thank you. Good evening, one and all, and respected President, sir. Thank you for the kind words. So, first of all, this is the second episode of our PKs, the auspicious guidance of our president, along with the team that already has been said, like Dr. Rajesh Kulkarni and Deepa Firke Madam, along with Dr. Sanjay Nathu sir and Dr. Madhavi. So, word and two about Madhavi. She has done a very great job in this today's series, and we know that she is a dedicated teacher as well as a learner always. So, congratulations, madam, for organizing this program of today's. And I think I'm missing Dr. Nathu. Yeah, he is there. And congratulations to you, sir, also for following this all the PG activity cases. So today it is OSCE plus the case based on pediatric nephrology. And under the leadership of Dr. Deepa Firke Madam and Dr. Bhavesh sir, with Dr. Supriya presenting the case. So we wish best luck to her. And today's experts, the judges or the examiners, as we say, Dr. Sati sir and Dr. Manish from Nagpur. So, welcome, sir, to our platform. And I think I would like to request Dr. Bela Verma, madam, to say a few words about this PG case. Madam, over to you, if you
Yeah,
are
good
there.
evening. Good evening, everyone. Very happy to see all my colleagues here. And PG case presentation founds one of the very strongest, foundations for the postgraduates because they get a wide exposure from so many experts, which would not have been possible in a single institute where they are. And I have myself witnessed this because I was part of the Central IP PG case clinics also. And I really thank the team for that hard work that they are doing to bring together the entire program. And I thank Dr. Kiran Sate for agreeing to be an expert here. I know him since many years, a very intelligent person who has helped out with many nephro cases in JJ Hospital. And I'm sure all of you will benefit from his expertise also. All the best for the program. Thank
Thank you,
you.
ma'am. Thank you for this opportunity, and I thank IIP and Bila madam for giving
No,
me
you're
this
most
opportunity.
welcome. You
Thank you.
are going to be part of our MAHAIP more often now.
Thank you, ma'am.
Yeah. Thank you. Thank you. Bye.
Welcome, doctor, and thank you, Bela ma'am. Over to you, Madhavi.
Thank you, Madam, Bela Madam, as well as Renu Ma'am, for such a kind gesture of arranging this forum. A couple of instructions for all. Please keep yourself mute throughout the session to avoid any disturbances while presenting and getting unnecessarily delays. All the questions would be answered at the end of the sessions. Hence, the audience is requested to put their questions in the chat box. We are indeed privileged to have with us distinguished experts. Dr. Mahesh Tiwari, Sir is a professor and head, Department of Pediatrics, GMC Nagpur, and EB member, AOP Nagpur. Sir has more than 20 publications in national and international journals and is currently authoring chapter in IIP book on OSCE postgraduates. He is PI in multiple research projects funded by NIH USA, and he has a special interest in cardiology, developmental pediatrics, and sickle cell anemia. We extend you a hearty welcome on behalf of MAHAIP, sir. Other expert for today's session is Dr. Kiran Sate, sir, who is a consultant pediatric nephrologist at Sir H.N. Reliance Foundation Hospital, Mumbai, a visiting fellow, St. John's Hospital, Bangalore, Heidelberg, Dallas, Texas, and Ghosh, London. He has 25 publications in index journals to his credit. He is the recipient of Best Clinical Research Fellow, Jaslok Hospital in 2010, and Best Oral Paper Award in Indian Society of Organ Transplantation, Mumbai 2012. We are very fortunate to have you on our panel, sir. A warm welcome to you.
Thank you, ma'am.
Today's renal case will be presented by Dr. Supriya Khedkar, Junior Resident 3, GMC Miraj, under the guidance of Dr. Bhavesh Shah, sir, Associate Professor, GMC Miraj. Sir has a vast experience of UG and PG teaching. Pre and postnatal psychology educator is one of the specialty. He's a coordinator IIP in accredited CPR center at GMC Miraj. He is also a national instructor West Zone for NRP, BLS, ALS as well as GM. He is a faculty for BCME as well as CISP, which are most important courses for being a PG guide as per NMC. He has special interest in basic emergencies, child education, psychology, basics of parenting. Moreover, not excelling only as an academician, he is a Himalayan trekker, marathoner, and a triathlete, having a Guinness Book World Record for running marathon on frozen Pangong Lake at the height of 14,000 feet with altitude being 0. Sir, a warm welcome to on this forum. Today's presenter is our JR3. Can I have a yes, Dr. Supriya Khedkar, who is pursuing her MD Pediatrics in GMC Meerut, motivated and academically oriented pediatric postgraduate resident with a strong clinical foundation, who has keen interest in pediatric nephrology, infectious disease, and emergency pediatrics. She is committed to evidence-based practice. She has already had a poster presentation on her credit at MAHAIAP Conclave 2025. She has postgraduate clinical experience in a renowned institute of GMC Meerut. We welcome Dr. Supriya. To give you a broad outline about today's PG session, it would be done in two parts: OSCE followed by the case presentation. This is our attempt to enhance the practice of OSCE for the students. I would share the details of each OSCE case. The delegates can mention their answers in the chat box while I would read the questions and Satya sir would discuss the case. We try to finish this session in next 15 to 17 minutes. For that, please be punctual and put your answers in chat box. Can we start?
Yes, yes.
Ma'am, is it
Next.
visible?
Yes, it is visible. We can go on the third slide. Yeah. So basically, this is antenatal ultrasound of a pregnant lady who has come to us showing the report at 28 weeks revealing mild bilateral pylectasis with reduced Liker volume. The first question goes, identify which of the following statements regarding fetal renal ultrasound is false. Option A, reduced Liker volume, echogenic kidneys, hydronephrosis, persistently distended bladder may suggest fetal renal disease. Option B, congenital anomalies of kidneys and urinary tract account for about 50% of the cases presenting with chronic kidney diseases in children. Option C, keyhole sign is diagnostic of bladder outlet obstruction. And option D, fetal renal development and urine production usually begins after 20 weeks of gestation. Any answers in the chat box? Anyone can mention the answers, need not be only postgraduates. We'll wait for a couple of Satya sir, should we start discussing?
Yes.
Okay.
So I think So has anybody given any answers? I think no, not yet, right?
No, not
so
yet.
We'll be hopeful for the second question. Yeah. So as we can see here, the correct answer is D, and we will discuss in the subsequent slides. So can we go to the next slide, madam?
Yeah.
So whenever we talk about the fetal kidney diseases, so antenatal ultrasound is a very important tool in picking up antenatal fetal kidney diseases, and this tool has helped us to identify these diseases much earlier than the symptoms and the signs which set in much later. So whenever we have a pregnant lady and who comes with an antenatal renal scan, and if it shows any of these, can we go to the next slide? So we'll go, I think. Next slide, please. Yeah. So any pregnant lady who shows the antenatal ultrasound features, the previous one. Yeah. So any fetal kidney which shows any of these parameters would be classified as an abnormal fetal renal ultrasound. So as we should be able to see is that two kidneys which are normally echogenic, they are not excessively echogenic or echo-bright. So that will be the first thing that is to be seen. Any degree of oligohydramnios will be a direct indicator of a fetal kidney disease, because the amount of liquor that is being produced is a major contributor is that of a fetal urine. So any fetal kidney which is not functioning normally would have reduced fetal urine output, and that would translate into oligohydramnios. So any echogenic bright kidneys, any kidneys showing cyst or any pelvic dilatation, so any antenatal hydronephrosis would also be an indicator of a fetal kidney disease. Similarly, any bladder, any fetal bladder which is persistently distended and does not empty. So on an ultrasound examination, we are supposed to be seeing the bladder filling and bladder emptying, and any bladder which does not empty would be a sign of a bladder outlet obstruction in the form of a PU valve. So that is a very serious condition, as we all know. So these would be some of the major things to be noted on the antenatal ultrasound. And in addition to that, if you find any extrarenal anomalies, which would also be suggestive of a syndromic association, and if you find such things, then definitely this fetus has a very high risk of kidney as well as other extrarenal anomalies, and these fetuses should be screened periodically till birth, and even thereafter immediately as soon as we can do an ultrasound and do the renal function estimation. So this would be the basic things that would suggest us that there could be a fetal kidney disease. So the first option that we saw, hydronephrosis, oligohydramnios, persistently distended bladder, and any kind of a echogenic kidneys would be definitely abnormal. Yeah, so this, as we can see the picture here, that shows a distended bladder, and we can appreciate the dilated posterior urethra. So this gives a appearance of a keyhole sign, and this is a suggestive of a PU valve or a bladder outlet obstruction, and it is a very sinister problem. And if we don't identify this and treat in time, it can result in like fetal renal failure immediately at birth, and can have long-term problems in the form of chronic renal failure, and even in acute situations, acute renal failure and urosepsis and vesico-ureteric reflux. So this problem, whenever we identify, has to be tackled immediately at birth. Can we go to the previous slide? Yeah. So whenever we have these antenatal renal defects identified, it is important to follow these children properly, because these factors will tell us that these are basically birth defects in the urinary tract, which is called as a congenital defects of kidneys and urinary tract, or CACUT. So CACUT is important because, as we can see here, 50% of the cases of chronic kidney disease in children, so those children who have a chronically reduced renal function after birth, 50% of these cases are going to be because of the birth defects in the renal tract. And if we are able to identify them in the antenatal period, we can treat the treatable conditions well in time, and we can prevent the progression of the chronic kidney disease by taking all the necessary actions. So by preventing nephrotoxic medications, or by preventing any recurrent UTIs, and relieving any obstruction, we can at least salvage the kidneys and can prevent the progression to advanced chronic kidney disease. So this CACUT becomes a very, very important category of conditions. And the other conditions which we know that which can progress to chronic kidney disease are the steroid resistant nephrotic syndromes, chronic glomerulonephritis, where the child may present with proteinuria and hematuria, and tubulointerstitial disease, which may come very silently, just as a unexplained rise in creatinine, which is progressively rising, and the child may have polyuria and bony deformities and unexplained anemia. So this could be a very silent condition that can also happen. And any child who has a recurrent urinary tract infection and develops pyelonephritis and subsequent scarring of the kidneys, that also can present with a chronic kidney disease later in life. And of course, drug-induced nephrotoxicity, as we all know, non-steroidal anti-inflammatory, which are given in children for fevers or pains, and especially if you give them in a condition of a dehydration or sepsis, where these multiple renal insults can add up and can lead to acute as well as chronic renal insufficiency. So these are all the common conditions that can progress to chronic kidney disease, and these children may land up into end-stage kidney failure, where you require dialysis or transplantation. And hence, whenever we identify any of these conditions, it is important to treat them adequately and ensure that they are properly controlled. And we should be able to stop any proteinuria, any hypertension that may progress further to the chronic kidney disease. Can we go to the next slide, madam? Next slide, please. Yeah, next slide, please. Yeah. So now when we have antenatal scan, it is very common to find a pylictasis or hydronephrosis, and which basically tells us that there is some dilatation in the renal tract. Now it is important to note that whenever we have these dilatations, all of them does not signify serious problems. And as we can see here, 50% of these conditions are going to resolve by the time the child is born. So 50% cases are transient, and only in those conditions which seem to be progressing on the further scans, like whenever you do a repeat fetal scan, and if you find that the AP diameter of the renal pelvis is increasing, so initially if it was 3 mm, then it becomes 6 mm, then it becomes 9 mm. So this increasing dilatation is definitely significant, and that may suggest a kidney disease which has to be evaluated after birth. So there could be different reasons why a fetus may have hydronephrosis. So the commonest being PUJ obstruction, that is pelvic-ureter junction obstruction. It could also be because of the reflux, that is vesico-ureteric reflux, or it could be because of serious problems like a PUJ obstruction or a PU valve, like the bladder outlet obstruction, the posterior urethral valve, and rarely it could be because of the other conditions as mentioned here. So whenever we have progressively increasing AP diameter, definitely these fetuses should be evaluated at birth, and all the obstructive lesions have to be treated immediately. Fine. And this is a guideline, as we can see here in the second trimester, what is the AP diameter cutoff, and the third trimester. So anything more than 7, 10 and 15. So this could be the cutoff that we need to follow these children properly. The diagram shows you a PU valve where there is a bladder outlet obstruction. A valve or a membrane is formed at the entry of the bladder outlet, and this simple mechanical obstruction is severe enough to cause entire urinary tract from being damaged. It can cause like harmful effect on the developing kidneys, so that at birth itself the kidneys may be completely damaged. The child may be born with a renal failure. The child may have a distended trabeculated bladder, as we can see here, because of the chronic obstruction, and this bladder does not function normally. And because of this, there is a high pressure in the bladder, and this reflects into reflux of the urine in the opposite direction, which is called as a vesico-ureteric reflux. So after birth, these children may have recurrent urinary tract infections. They may have dysplastic kidneys, which are not normally formed kidneys. So the creatinine may be high, and so that may be a problem at birth. They may have acute renal failure, and even when you treat this acute renal failure by removing the obstruction, later on these children are going to progress to chronic kidney disease. So this PU valve is a very, very serious condition, and one should be aggressive in management and trying to relieve all the harmful effects that this condition puts on the developing kidneys. Yeah, I think that we have discussed. There is one more slide, the last slide. Yeah, so now the last option was that fetal urine production and fetal development of the kidneys begins after 20 weeks. So that is an incorrect statement. As we can see here, the fetal renal development begins very early in the fetal life. That is in the first trimester itself. By 7 to 8 weeks itself, it starts developing, and by 9 to 12 weeks, you can actually see the urine in the fetal bladder. So the first trimester itself is a very, very important phase for major organogenesis, and if there is any problem that happens in this phase, we are going to have serious fetal renal problems. So the correct answer is that it should be at the end of the first trimester, or 9 to 12 weeks. And whenever we have oligohydramnios, it directly tells us that the fetal kidneys are not producing adequate urine, because after 20 weeks, the 90% of the amniotic volume is by the fetal urine. And this can have adverse effect on the lung development as well as the skeletal problems. So you may have children with pulmonary hypoplasia at birth, and also with club feet, because the volume is less, and hence there is a compression of the fetus within the uterus. So this is going to be the important things to be kept in mind. So I think that answers the first OSCE. Can we go to the next one?
Yes,
Yeah.
sure, sir. Very beautifully explained the clinical, pathological, as well as the antenatal sonography when it comes to us, or sometimes to the fetal medicine expert, what is to be done. Coming to the next OSCE, 3-year-old boy presents with generalized swelling and urine protein 3+. He is diagnosed with nephrotic syndrome. His urine protein continues to be 3 plus even at the end of 6 weeks of daily steroid therapy at 2 milligram per kg per day. Which of the following statement is true? Option A, 6 weeks of further alternate day prednisolone therapy should be continued to see remission of proteinuria. Option B, he has primary steroid resistant nephrotic syndrome and would need additional genetic testing and a kidney biopsy. Option C, long-term risk of kidney failure is minimal in steroid resistant nephrotic syndrome. Option D, MCNS, minimal change disease, is the most common renal histology pattern in steroid resistant nephrotic syndrome.
Yeah.
We have got multiple options. 50% of the option chosen is A as the correct answer, and 2 answers are as option B.
Okay.
Over to you, sir.
Yeah. So I think few of them have answered correctly. So whenever we say that at 6 weeks a child who has nephrotic syndrome has not responded to steroids, that itself tells us that this child has a steroid resistant nephrotic syndrome. As the standard definition tells us that 4 to 6 weeks of daily steroids at 2 milligram per kg per day is sufficient enough to induce remission in those children who are going to have steroid sensitive nephrotic syndrome. And that happens in almost 95% cases. So the correct answer is that at the end of 6 weeks, if you don't see a urine protein becoming nil or trace, or urine protein creat ratio becoming less than 0.2, then you would label this as a steroid resistant nephrotic syndrome, and then you should not proceed with the further alternative therapy, because then you are not treating it as a steroid sensitive nephrotic syndrome. And the next option, next treatment plan should be at 6 weeks, when you don't have the remission, you have to do certain additional tests to identify what is the condition that the child has, what is the underlying histopathology. So a kidney biopsy definitely would be indicated, because the further therapy would be then chosen depending on what is the histopathology pattern, whether it is a focal segmental glomerulosclerosis, which is the commonest pathology that is found in steroid resistant cases, followed by minimal change. There could be other patterns like membranoproliferative GN, glomerulonephritis, membranous glomerulonephritis, and there could be even rare conditions like mesangial-proliferative glomerulonephritis, like IgA nephropathy. So when the correct answer is that the 6 weeks you should not proceed further with the alternative therapy. Then the second option is that he has a primary steroid resistant nephrotic syndrome and would need additional kidney biopsy and genetic testing. So this is also the right option. So basically this is the right option. So now why genetic testing? So we all know that a kidney biopsy is required, but now studies have shown that whenever you have a primary steroid resistance, that means at the first instance itself, the child has not responded to steroids. It has been found that 30% of these children may have genetic mutations in the glomerular basement membrane, that is a podocyte protein, and this basically tells us a lot of information as to what is the natural history going to be. So a genetic testing would be more informative, and it would tell us whether this child has got a genetic condition where immunosuppression may not be that effective, and hence instead of a kidney biopsy, you may even first do a genetic testing, and if the genetic testing does not show any genetic disease, then a kidney biopsy definitely would be warranted, because kidney biopsy is definitely an invasive procedure. So if you have another option in the form of a gene testing, a whole exome sequencing would be a better option that you can do first. Fine, because if you have conditions like FSGS or like any other pathology, then you would avoid a immunosuppressive therapy, because more immunosuppression if you are going to induce, it is going to cause increased risk of infections in these children. So definitely then gene testing would be important. Long-term risk of kidney failure is minimal in steroid-resistant nephrotic syndrome. That is the incorrect option. So as we understand, whenever you have a steroid resistance, this pathology is going to be more complicated, and these children are not going to respond to the normal medicines like steroids. You will require more second-line therapies, and definitely because of the continued proteinuria that these children have, so because they are not going into remission, this proteinuria continuous is going to cause more damage in the kidneys, and in the long term, almost 30 to 50% will have progression to chronic kidney disease. So definitely the risk of kidney failure is very high in steroid resistant nephrotic syndrome. And minimal change is the most common histopathology pattern, which is also incorrect. As we just discussed, that focal segmental glomerulosclerosis is the most common. When you have a steroid sensitive nephrotic syndrome, 90 to 95% will have a minimal change disease, and that is usually synonymous with a steroid responsive nephrotic syndrome. So the correct option here would be B. that this child has a primary steroid resistant nephrotic syndrome and needs additional testing. Can we go to the next slide? We have just shown,
Sir,
yeah,
sir, it's already 9:30.
okay.
There's a
I think,
request.
yeah, we can go
We'll
to
first
the,
take our PG
yeah,
case
yeah, sure,
presentation so that
fine.
it will be beneficial to the audience, and
Yes,
we will
yes,
come back to our
yeah,
OSCE. There are three
sure,
more interesting cases in the OSCE.
yes,
So we will
yes,
first proceed with the case
sure,
presentation. May I
yeah,
please ask Dr. Supriya to start presenting her case without much ado?
yeah.
All the examiners, experts are requested to ask the questions where and where itself they feel it is necessary for the from exam point of view. Dr. Manish Tiwari sir, Dr. Bhavesh sir, and Dr. Kiran Sathe sir.
Yes.
Please start, Dr. Supriya.
Yes, ma'am. Good evening, all. A 3-month-old female child born by vaginal delivery, preterm 34-weeker, third-degree consanguineous marriage, informant mother who is reliable, admitted in PICU on 31st December 2025. Chief complaints were loss of weight since 15 days, crying during maturation, along with decreased urination since 2 days, that is 2 to 3 times in 24 hours, and fever since 1 day. Baby was apparently all right 15 days back when she started losing weight despite adequate feeding. Baby has gained weight till 3 kg in 2.5 months. That is poor weight gain, which was suggestive of failure to thrive. Now, since 2 days, mother is complaining of decreased urination along with crying during maturation. Since 1 day, baby is having fever, acute in onset, high grade, not relieved on medication. No history of chronic diarrhea, no history of vomiting, no history of excessive sweating, no history of increased respiratory distress, no history of any feeding difficulty was there. Past history, there was history of NICU stay for 18 days in view of preterm 34-weeker with respiratory distress, which was diagnosed as congenital pneumonia and culture positive sepsis. And also history of cough on and off for 1 month was there, taken treatment on OPD basis. Family history, third-degree consanguineous marriage. One elder sibling was there, 2.5-year-old, and this present child is 3-month-old. Family history is not significant. Antenatal history. History of polyhydramnios was present. No history of maternal diabetes or hypertension. No history of maternal drug intake. No history of torch infection was there. On asking regarding the urine output of the baby, mother told that there was history of polyuria. That is urine passage 20 to 25 times per day. And regular antenatal checkups were done. Birth history. A baby was preterm, 34-weeker, born by vaginal delivery, cried immediately after birth. Birth weight was 2.2 kg and NICU stay for congenital pneumonia with culture positive sepsis. Developmentally, baby was appropriate for age. Immunization history, only BCG vaccine was taken at 2.5 months of age and OPV first dose taken. Rest of the vaccination was not done. Dietary history, baby was on exclusively on breastfeed. Anthropometry, baby was come under severe acute malnutrition. On general examination, signs of severe dehydration were present. Skin pinch was delayed, that is more than 3 seconds. Sunken anterior fontanelle was there, and
Wait,
baby was
wait, wait.
lethargic.
Supriya, I just
Yes,
want
sir.
to know when does this transmission from polyuria to oligouria took place? Were there any precipitating factors for that?
Only patient was having decreased intake of the feed, and associated with that loss of weight also started. And only since last 2 to 3 days, baby was having oliguria along with the fever.
Right. So was there
So
any
the
history
weight
of,
loss was also very acute.
Weight loss was since 15 days, but since birth only weight gain was not appropriate for the age. Weight gain was only 3 kg till 2.5 months of age.
right. So as you rightly mentioned that whenever you have a like preterm child or a newborn baby who is polyuric and has a history of polyhydramnios antenatally, what will be your thought process and what conditions will you keep in mind? So what are the things when you have a polyhydramnios will be the differential diagnosis? Different things that come to your mind. So
Hello,
there could be different conditions, not only renal but extra-renal also.
hello.
Yeah, yeah. Hello, we can hear you. Hello.
Hello.
Yeah, yeah.
Yes, Supriya
So,
sir, you are audible.
Sorry, sir, can you repeat, please?
yeah, can you
Hello.
tell us a few conditions which could be present in a child who has antenatal polyhydramnios?
Yes, sir. Huh.
So, what are the conditions that you know of? Anybody else would like to volunteer or
Hello.
hello? Yeah, we are able to hear you. Hello.
Sir, you are audible. I think Supriya is not getting you.
Yeah, is there anybody else who would like to answer?
The conditions like gestational diabetes and esophageal atrasias can present with polyhydramnios.
Yes, that is very correct. So
And
whenever we have a
ocular
block in
atresia.
the yeah. So whenever we have a block in the GIT, as the fetus kind of drinks the liquor, so any block in the GIT, like any atresia, esophageal atresia, or any GI atresia, that is going to have the polyhydramnios. And the other common condition is the maternal, Bartter syndrome. So where the fetus produces polyuria, and that results into polyhydramnios. So Bartter syndrome and GI atrasias would be the important conditions that one should keep in mind when you have antenatal polyhydramnios. Fine. So now this child, as you rightly mentioned, that the child had polyuria after birth. So again, which conditions come to your mind when you have a polyuria in a neonatal period?
So if polyuria is presenting in neonatal period, my differentials will be diabetes insipidus, nephrogenic diabetes insipidus. It can be any tubulopathy like Bartter syndrome, Gitelman syndrome.
Right. So the polyuria, when you have, it could be because of two major causes. First, it could be because of water diuresis. That means the child is not able to concentrate the urine and the water is getting wasted as a form of polyuria. Or it could be because of salt wasting. That means the sodium chloride, potassium, these salts are getting lost in the urine, and because of which there is also solute diuresis. So along with the salts, the water also gets lost. So it could be either a pure water diuresis, or it could be a salt and water wasting. Fine. So these could be the things, as you rightly mentioned. It could be a diabetes insipidus where it is only pure water diuresis, or it could be Bartter syndrome or any of the salt wasting disorders, which could also be in the form of renal tubular acidosis or
Yes, sir.
hypokalemic metabolic alkalosis like Bartter syndrome. So at this point of time, one could keep in mind both these things if you are just focusing on the polyuria. So even any kind of a tubulopathy which has salt wasting would be an important condition to be kept in mind. Yeah, so it
Dr.
could be
Bhavesh
RTA.
Sars, sorry to disturb you, but Dr. Bhavesh Sars sir also wants to say something.
Yes.
Okay, so Dr. Supriya, I just want to go to basic. How did you diagnose polyuria? Because I can see the history of only passing more urine number of times. Is it enough to really diagnose polyuria and then to go ahead with it?
Yeah. Is there any way to quantify what you're saying?
Only frequency was there, sir. Mother was telling ki baby was passing more frequently urine, that is 20 to 25 times per day. Usually, since birth, around 1 month, baby was passing like 10 to 15 times per day.
So is it polyuria is defined on the frequency or it is a volume of the urine per day?
It is defined according to the volume of the urine per day, but on history basis, only frequency was there.
So that's what I'm asking. Okay. So I guess you must be understanding that it must be volume calculation to really define polyuria because
Yes, sir.
frequency can be increased in many conditions. And what we're discussing is really polyuria.
Yes, sir.
I hope.
So,
Okay. Thank you.
so normally, if this child is admitted with in the NICU, then one would definitely have the intake output charting, and that would be able to tell you whether this has got more than 4 ml per kg per hour as a urine output, which could be in the form of a polyuria. So I think,
Yes,
as
sir.
sir rightly said, quantification would be important before you label it as a polyuria. Fine.
Yes, sir. Yes, sir.
So yeah. So any child who has a
Mm.
polyuria and has been feeding well but still has weight loss, so that basically tells you that this child is not able to, he has a urinary concentration defect, and which is resulting into like inadequate weight gain or weight loss. So I think
Yes,
these
sir.
are two or three features that you presented so far: polyhydramnios in antenatal period, polyuria which needs to be quantified, and a weight loss despite feeding well. So that would
Yes,
be important things to be kept in mind. Yeah.
yes, sir.
So
So, Supriya, once again coming to the same question in which the frequency you have pointed out.
Yes, sir.
So, so can you tell me what is double voiding or incomplete voiding, and what can be the causes for that in the neonatal period?
Sorry, sir, I don't know.
Okay, it is commonly seen in reflex diseases or if there is a diverticulum.
yeah, so basically, if you are able to identify a significant drop in the urine output from the high increased frequency, it has suddenly dropped. Then definitely we need to find out why is it happening. Is it like an acute kidney injury where this child has gone into dehydration-induced AKI? So that could be one reason. Or is there any other reason why the child has developed acute drop in the urine output? So without quantifying, we will not be able to really guess what is happening to the urine output, and hence quantification would be definitely important. How would you define oliguria, like as similar to what how you define polyuria? So what is the definition of oliguria in neonates?
Uh, a decrease in frequency of passing the urine. That is what.
Quantity wise, beta. It is in quantity in
If it
terms of.
is,
Yeah, so as we said, more than 4 ml per kg per hour would be polyuria. So
if it
do
is
you know
less
what?
than 0.5 ml per kg per hour.
Yeah. So you need to have less than zero point 0.5 to 1 ml per kg per hour to call it as a oliguria. And yeah, so I think that would be important things to be kept in mind. You need to quantify the urine output.
Yes, sir.
Fine. Fine. So you have shown here signs of dehydration in the form of sunken fontanelles, lethargy, and skin pinch. What could be the other reasons why the child may have dehydration and decreased urine output in the neonatal period? Is the child being breastfed or was the child on formula feeding? Hello?
Yes, sir.
Is the child on breastfeeding or on formula feeding?
No, sir. Baby was not on formula feed. Baby was on exclusively breastfeed.
Yeah. So do you know of any common condition which happens in newborn period and where the child may come with dehydration and decreased urine output, and it could be related to inadequate feeding, and hot weather. So any of that condition, do you think what could be that condition? Which is quite common in many parts of where you have a hot weather. So hypernatremic dehydration, which is very common in newborn babies, especially in the primaries where they are not frequently feeding, and they may come with dehydration, irritability, and may also come with acute kidney injury if it is a very severe hypernatremic dehydration where you have a drop in the urine output. So this condition also needs to be kept in mind until the time you have done the investigations. And so at this point of time, you will keep these three differentials in mind, and you will proceed with the further examination.
Yes, sir.
Fine. Have you mentioned the blood pressure? You have mentioned normal. So what was the blood pressure?
I also wanted to ask, actually, you can't write normal. You have to write the actual figures and age-wise, what is the blood pressure?
Yes. Yeah, because it's all centiles, no, according to the centiles. So if it is a hypotension, so I think that figure has to be mentioned and it has to be properly
Yes.
recorded. So now you
Okay,
have
sir.
mentioned no ambiguous genitalia. Is there any condition where the genitals could be ambiguous and they may come with a similar presentation that you described, that polyuria and do you know of any condition which can have ambiguous genitalia?
Yes, sir. Congenital adrenal hyperplasia can present like ambiguous genitalia in neonatal period.
Right. So, and this child is a female child, right? Hello, this is a female child.
Hello.
Hello.
Hello, Supriya.
Yeah.
Hello.
Sir is asking something.
Yeah, this is
Hello.
a female child, right? So, do you
Yes,
know
sir.
of any?
Yes, sir. This
Yeah.
is a
So,
female child.
yeah. So, congenital adrenal hyperplasia. What could be the complication that could present with polyuria and weight loss? So, which is a typical complication that you know of? So, basically, they have salt wasting
Salt wasting.
condition.
Yes, sir.
Yeah.
There salt wasting.
Yeah, so whenever you have any ambiguous looking genitalia and polyuria, you have to think in mind in terms of the salt wasting because of CAH, so
Yes.
which is an important complication. Yeah, so I think these 3 or 4 conditions you would keep in mind at this point of time. Yeah.
Yes, sir.
Is there anybody else who wants to ask anything? Madam, Bela madam, you want to ask anything?
I just wanted to know, Ki, since we are not seeing the patients in these PG case presentations, would it be worthwhile to put a few clinical photos of the patient so that, we
Yeah,
get a general look at the face of the child for any syndromes and
yes.
any other local photos that you want to put up? That gives a better idea when we are, at the history and differential diagnosis. So it will help us to know what you are going towards.
Yes, that is important because especially in conditions like Barter's or any other condition which has syndromic facies, those also would be important things to be noted, and then you can correlate with the clinical signs that you would present later.
Dr. Supriya has put a couple of photos in the last slide, Supriya.
Yes,
Okay.
sir. Yes, ma'am. I have photos of the patient. At
No,
last.
it could be with your clinical history presentation also for us to be
Correct.
on the right track because we
Right.
have not seen the patient.
Yes.
Okay, the other question that one needs to answer is that did the child receive any nephrotoxic medications which resulted in sudden drop in the urine output? And if yes, what could be the different nephrotoxic medications at this point of time that the child may get when the child is admitted in NICU because of some sepsis or fever? So which are those medicines that you should keep in mind and should not be given when you are suspecting a kidney condition?
Mainly aminoglycoside groups, sir, like
Okay.
vancomycin, gentamicin.
Okay. Any other uh, drug which is frequently given for controlling fever and pain, which are
Analgesics,
yeah. So which analgesics?
ibuprofen. Yeah.
Yeah. So that is right. So non-steroidal
Yes.
anti-inflammatory and the aminoglycoside group of drugs are the nephrotoxic medications. And do you know how do they cause nephrotoxicity or acute kidney injury in the neonatal period?
Because these
So
drugs clear by the kidney route only.
yeah. So do you know what is renal autoregulation? So basically, the kidneys they try to maintain the renal blood flow by adjusting the tone of the afferent and the efferent blood vessels or the afferent and the efferent arteries. So in any child who has sepsis or dehydration, the afferent would dilate more so as to maintain the normal GFR. Fine. So when you give in a child who is already sick, like a dehydrated child or a sick sepsis child, if you give additional nephrotoxic medications, then the ability of the kidney to maintain this glomerular filtration rate is compromised, and this can lead to sudden drop in the renal blood flow, and that can present into acute kidney injury. Hence, all these medications should be as far as avoided when you are having sick child. Fine. So that is an important message that we should keep in mind.
Yes, sir.
Fine. So basically, by disturbing the renal autoregulation, they land into acute renal failure.
Yes, sir.
Fine. So the one reason that your polyuria has suddenly gone into oliguria, this also could be one of the reasons. So you have to keep in mind. Okay.
Yes, sir.
Yeah. Madam, shall we go ahead? Sir, would you like to add anything?
No, we can go
No,
ahead.
I think she can go ahead.
Yeah.
Yes. On general examination, patient was having signs of severe dehydration, skin pinch more than 3 seconds, sunken anterior fontanelle, lethargic, pulse rate was 134 beats per minute, regular, low volume, equal in all limbs, respiratory rate was 34 per minute, regular, no tachypnea, no retractions were there, pallor was absent, edema was absent, blood pressure was normal, and no ambiguous genitalia was there. On systemic examination, CNS findings, infant is lethargic and poorly responsive to surroundings and weak cry was there. CVS wise, S1, S2 was normal and no murmur was there. The respiratory system was also normal and per abdomen examination was also normal.
So, as Madam rightly mentioned that BP you have just mentioned normal. So, in a child who is dehydrated and such severely affected, how would we expect that the BP remains normal? Because what would we normally expect? Would you expect a hypotension or a normal BP in a dehydrated child? What is the usual observation that you find?
Even the heart rate seems
Usually,
to be quite normal for a
Yeah,
severe dehydration patient.
yes. So you would expect definitely tachycardia, even a tachypnea, because if there is a dehydration, there could be metabolic acidosis, there could be lactic acidosis if there was a sepsis. So definitely these parameters need to be verified, and we need to be sure what we are presenting in background of the situation that you are describing, whether they are fitting with the clinical picture.
yes, sir.
Fine. So I think we need to double check what was the blood pressure, heart rate, respiratory rate, and peripheral perfusion. So definitely it does not fit. Yeah. So I think yeah. Please go ahead.
According to the history and examination findings of dehydration, polyuria, failure to thrive with prematurity and history of polyhydramnios, my differential diagnosis were Bartter syndrome first, second pseudo Bartter syndrome, third is nephrogenic diabetes insipidus, renal tubular acidosis, and chronic kidney disease.
So I think you have given a complete list of all the conditions that can be seen. So it is not easy to put out differentials with such a limited information that you have. So you may just say that there is a polyhydramnios and definitely a polyuria which you have noticed but needs to be quantified. So you can at this point of time just say that it could be possibly a renal disease that this child has and which needs to be quantified. It could be either a Bartter or Bartter-like syndromes, which needs to be confirmed by doing a biochemical estimation. But you really can't say the pseudo Bartter and all, because which are the pseudo Bartter-like syndromes which you know of? Because there has to be
Cystic
some addition.
fibrosis.
Yeah. So what would be the additional finding in cystic fibrosis that you know?
Cystic fibrosis patient can have recurrent respiratory tract infections. Maybe
Okay.
that patient will have chronic diarrhea, that is malabsorption like presentation.
Okay.
What
So
would be
I
the
think
presentation in neonatal life of a cystic fibrosis patient? And how much common is it in this part of our country?
Cystic fibrosis is a rare syndrome. It can present in neonatal period like chronic respiratory failure or delayed passage of the stool.
yeah, so meconium block. So that is, I think, a more common presentation. So delayed passage of stool could be one of the thing. And I think you presented that this child had recurrent pneumonia.
Uh,
Did
yes,
you
sir.
present somewhere?
On and off cough was there for one
Okay.
month, which for which they have taken treatment on OPD basis only.
So was it a LRTI or it was just like a pneumonia or it just viral cough and
Only
cold?
viral only, sir.
Fine. So why is that important? Because if you are suspecting cystic fibrosis, then all these recurrent pneumonias become important differentials because they have those kind of a presentation, chronic lung disease. Yeah, so I think it would not be easy to think of these conditions, which is other hallmark sign in cystic fibrosis. Anything on the skin that you find in these children? That is a classic. Some taste that you find.
That is used as a diagnostic criteria
Hello,
also.
hello.
Any typical taste to the skin when the mother
Sweat chloride test,
tries?
sir. Sweat chloride test for cystic
No,
fibrosis.
what would the mother tell you that when she tries to kiss the baby, what would be the type of taste that she gets in a
The
cystic
salty
fibrosis?
test,
Yeah, so that is
salty
a
test.
so that is the first thing that the parents usually highlight, that this child is always, you feel salty when you kiss the child. So that becomes the first thing that you would keep in mind. Fine.
Yes,
So you can just at this point of time, it is more like looking like a renal because of the polyuria, dehydration, acute drop in the urine output, and polyhydramnios in the antenatal period. So we could just limit it to a renal condition with polyuria, which could be either a water diuresis or a salt wasting condition. Fine. So the other things
yes, sir.
definitely we would have to confirm on the biochemical testing.
Use,
Yes,
I
sir.
think CKD to label the patient CKD is quite early.
Yeah, yeah. So when would you call it as a CKD, and what is chronic kidney disease? Can you just tell us? What do you understand by term chronic kidney disease? This child is currently 3 months, no, you said?
Hello.
Yeah, this child is currently 3 months old. And what is chronic kidney disease? Why have you thought of chronic kidney disease at this point of time? Hello? Are you able to hear us?
Dr.
Hello.
Supriya?
Usually, chronic kidney disease we usually define if renal disease is more than 3 months.
Yeah, so
It is-
So any condition which like persists for 3 months in the form of abnormal symptom or abnormal sign or abnormal biochemical pattern or test, that would be telling you that this condition is not acute or not reversible on its own, and as a result it could be a chronic kidney disease. Fine. So chronic kidney disease itself is not a diagnosis. It is basically a condition that may be because of some kidney problem. Fine. So you can just say that it is a kidney disease which is in the form of a polyuria or a salt wasting disorder. And if you find that this condition continues in the long run, then you would like tell it that this could be a basically like a chronic kidney disease. But by itself to label it as a CKD without any proper etiology would not be the right approach to put a diagnosis. Fine. So I
Yes,
think
sir.
we can be just uh, it would suffice to just say that it is a renal condition presenting as a polyuria in the neonatal period with a dehydration and antenatal polyhydramnios. Fine.
Yes, sir.
Yeah. Can we just proceed now further?
Yes, sir. At admission, patient was having severe dehydration signs, so plan C of dehydration correction was started. Investigations at admissions were suggestive of hyponatremia and hypokalemia. That is, sodium was 116.4 and potassium was 2.4. So IV 3% NaCl correction and oral potassium correction has been started. This correction given for 24 hours, and then we repeated the serum electrolytes. After that, serum electrolytes were normal, that is sodium 130 and potassium 3.9. So electrolyte correction was stopped.
Can we
But
stop here? So whenever you have, can you go to the previous slide? Yeah.
yes, sir.
So whenever you have a dehydration and you have such a severe hyponatremia and hypokalemia, what would be
Yes,
the
sir.
first thing that you would think of rather than first directly giving sodium correction and potassium correction? You would try to find out where is the loss happening, right? Why is this such low? So would you find out that what is the cause of such a low sodium and potassium? How do you confirm or how do you find out? Is it because of poor feeding or because of hypernatremic or hyponatremic dehydration or any other reason that this child already has? So that increased frequency of urination that you noted. So how would you confirm that what is the cause of this hyponatremia? So what would you
Uh,
test?
so, uh, urine osmolality we can do, sir. Also serum osmolality to differentiate from diabetes insipidus.
No. So do you get hyponatremia and diabetes insipidus or what do you get?
In diabetes insipidus, we will get hyper hypernatremia.
Yeah, because it
And
is a free
urine
water loss.
osmolality will be low, sir.
Yeah, so no, the right answer is that when you have a hyponatremia and hypokalemia, and when you have a polyuria, you are basically trying to find out whether the polyuria is having salt wasting. Fine. So your
Yes.
answer would be I would check urine for electrolytes wasting. So I would check urine for sodium, potassium chloride, and if the urine potassium and chloride sodium is high in the urine with low serum sodium and potassium, it would tell me that this is a renal salt wasting, which is causing dehydration and hyponatremia and hypokalemia in the neonate. Fine. So
Yes,
serum
sir.
osmolarity and urine osmolarity in this situation is not required because it does not fit with a diabetes insipidus like presentation. Fine. If you had a
Yes, sir.
hypernatremia and polyuria, then you would think in terms of a diabetes insipidus, and there the osmolarity would be important. Fine. So the
Yes, sir.
important point would be to check for urinary electrolyte to see for renal wasting. Fine.
Yes, sir.
And then after you have confirmed that, then you would proceed with the treatment, which would definitely be in the form of replacement of sodium and potassium, as you rightly mentioned. How did you
Yes, sir.
calculate the sodium correction, and what is the formula that you would correct?
Hmm. I would like to add something. The correction was quite rapid, I should say that.
Yeah. So 116 to 130 in 24 hours. So what is the normal rate maximum that you should correct?
IV 3% NaCl correction rate was, sir, we can give 0.3 to 1 ml per kg per hour. So we have given by the rate of 0.5 ml per kg per hour, sir.
No, how do you normally correct hyponatremia? Means what is the formula? 0.5 ml per kg per hour is not a routine formula that we use. How do you calculate sodium correction that you need to give? So basically, you need to know whether it's a symptomatic hyponatremia or is it a very severe hyponatremia. So 116 definitely is a very, very severe hyponatremia. And what are the risks that you may have at this low sodium? What are the problems that you can encounter? And that's why you are trying to replace it as quickly as possible. What can go wrong when
Cerebral
you
edema can occur, sir, because of hyponatremia.
no. So when you have a primary hyponatremia, you are mainly worried about convulsions, which can,
Yes, because of cerebral edema, patient can go into convulsion, sir.
cerebral edema does not happen because of primary hyponatremia. It happens when you are treating hypernatremia with free water and suddenly dropping the sodium. So it is the other way that you get cerebral edema. In this situation, you are mainly worried about seizures, hyponatremic seizures. Fine, and
Yes,
that's
sir.
why you are trying to correct the sodium. But as sir rightly mentioned, the rate of correction cannot be more than what? So what is the maximum correction that you can do in 24 hours?
10 to 12 millicolon per
Yeah.
kg, sir. Yes.
Yeah, so I think that is the right thing. So you cannot rapidly correct because what can happen if you rapidly correct the sodium from low sodium if you rapidly increase it? What is that condition called?
Pontine
Yes.
myelinolysis, sir.
Yes. So both rapid correction of sodium and rapid drop of sodium both are equally dangerous, and hence I think we need to be very careful. Fine.
Yes,
So
yes, sir.
yeah, so normally you would correct sodium as per the dehydration correction and try to correct the sodium gradually. But in a acute emergency situation where you have such a low sodium, you would try to give 3% NaCl and try to raise it to a safer level that is more than 120. Fine. So how much is the 3% NaCl volume that can raise serum sodium to a safer level? Do you know how to calculate that formula?
No, sir.
Anybody else in the audience would like to, any other PG student? So normally 4 to 6 ml per kg that you would give over a few hours, that would raise the serum sodium to a safer level. So you would definitely not give rapid bolus and try to raise the serum sodium because that would be dangerous. So this
Yes,
0.5
sir.
ml per kg per hour, that is what you have said, no? So that
Yes,
you
sir.
could correct, and you can give up to 2 to 3 or up to 4 ml per kg in the next couple of hours. So that would raise the serum sodium to a safer level. Fine.
Yes, sir.
Yeah, so the step one would be checking urinary electrolytes and then simultaneously starting the correction and also replacing the fluid losses. So you would give fluid volume correction as well as the salt correction that is being lost.
Yes,
Fine,
sir.
because you are also wanting to treat the dehydration, which is quite severe. So that you said it was, how much was the percent dehydration? Severe dehydration
Hello.
is what percentage of dehydration?
Hello.
Yeah, what is the percentage of dehydration that you calculated?
Percentage of dehydration. Hello.
Yeah.
Yeah, that will help you to calculate the total water deficit which is there in the body.
What is the percent dehydration that you know of? What are the different categories of dehydration percentage? And how do you calculate the fluid therapy then that you would be giving to the child? Hello, are you able to hear us?
Hello.
Yeah, are you able to hear us? How do you calculate the percentage dehydration that the child has, and how would you plan the fluids?
Mm.
So it is between three to six, 6 to 9, and more than 9, na, beta.
Yes, sir. Hello.
Fine. So you need to
Yes.
calculate that, and you need to give maintenance fluids, correct the dehydration as per the percentage of the correction. Yeah. And
Yes.
then simultaneously replace the ongoing losses. So this will be the three parts of the correction: the bolus to correct the deficit, the maintenance, and the ongoing losses. Fine. So this would be the type of correction that you would do. At the
Yes,
same
sir.
point of time, you have to keep in mind if the creatinine, the child has gone into sudden drop in the urine output, whether this child has gone into acute kidney injury, and whether the child would tolerate so much of fluid. So a creatinine definitely has to be seen, whether the creatinine has suddenly risen. Fine, because
Yes.
when you treat AKI, it is not just fluid that you're giving. You have to be very careful about the excess fluid that may cause fluid overload. Fine, so I think
Yes, sir.
very rarely severe dehydration may land into acute tubular necrosis, and where the excess fluid may be also equally dangerous. Fine, so I think you need to simultaneously look at the renal function also, the creatinine, BUN, and then plan the further therapy.
Yes, sir.
Fine. So you got the idea, na, that the correction has to be according to the percent dehydration.
Yes,
Yeah.
sir.
Can we go
Yes.
ahead?
Yes, sir.
Any other electrolytes which were said?
Sodium,
Why only
potassium, and
sodium, potassium? Why not
calcium
Yeah.
was.
calcium, chlorides?
Yes, sir.
Yeah.
We have
And
sent all that.
Yeah. Can we see the?
Yes, sir.
Can you magnify this? It's the table that you showed now.
This is a VBG of that patient, sir, which was suggestive of mixed respiratory and metabolic alkalosis.
What is the pH? 7 points. How much?
pH was 7.69, sir, and PCO2 29.8.
Okay. And what is the bicarb?
Can I proceed further, sir?
What is the bicarb in the venous blood gas?
Hello?
Yeah. What is the bicarbonate?
Hello?
Yeah. Are you able to hear us? What is the bicarbonate?
Bicarbonate was, sir, 35.2.
Yeah. So do you think it is a primary respiratory alkalosis or a metabolic alkalosis?
Hello?
Yeah, what is the primary condition that has resulted into alkalosis? Is it a metabolic or a respiratory? Hello? Hello?
Hello?
Yeah, so what is the primary problem that you think the child has got as alkalosis? So given the background that you have, the polyuria and the renal disease that you are suspecting, when you have a alkalosis, what is the primary cause of alkalosis that you think of? Is it going to be a primary respiratory cause or a primary metabolic cause?
It would be primary metabolic cause, sir.
Yeah,
and you have written mixed respiratory, beta. I think it is just for
Yes, sir.
compensation.
yeah.
Yes, sir. That was, yes, sir.
Only
S- Yeah, so you have to
29.7.
Yes, sir.
find out what is the degree of compensation and whether it is right to say mixed. So one would think of primary metabolic alkalosis. And in addition to that, you have shown hyponatremia, hypokalemia, and
Yes,
what is
sir.
the chloride? The chloride is, I think, how much have you shown
Raised.
chloride?
Yes.
It's 130, it's raised.
130. Yeah, so normally, what is the type of picture that you get in a like metabolic alkalosis, where you have hyponatremia, hypokalemia? You would be expecting a hypochloremic alkalosis, right? Because when the salts are getting wasted, it's usually loss of sodium, potassium, as well as chloride. So, is this after some correction that you have got this venous blood gas, or was this the first venous blood gas that you got?
This was after first correction, sir.
Yeah, so what was the first blood gas and what was the chloride in that blood gas or the electrolytes that you sent? So, have you checked the chloride in the first set of samples that you sent? So the message that we are trying to give here is that if you are able to identify a pattern that the child has a polyuria, dehydration, and metabolic alkalosis, and if you have a hyponatremia, hypokalemia, and hypochloremia, then this becomes a pattern of Bartter-like presentation, and then you can think in terms of that pathology. Fine, but
Yes,
after
sir.
correction, if you are getting some uh, like different results, then it would be difficult to analyze this VBG in terms of the findings that you were getting earlier. Fine. So
Yes,
you
sir.
need to see whether it was a hypochloremic alkalosis that you had earlier. Fine.
Yes.
Yeah. So the child has basically alkalosis on the background of the polyuria and the polyhydramnios. So now, what is the thing that you are like thinking? What is the differential diagnosis? You want to show any further slides? You can just complete the investigations.
Yes, sir. Urinary pH was suggestive of alkaline urine. Serum
Okay.
chloride was suggestive of hypochloremia, that is, serum chloride was 78 milliequivalent per liter.
Yeah, but you are
Serum magnesium was normal, 2.2 milligram per DL. Then urinary electrolytes was on higher side, that is, urinary chloride was 759.5 millimole per liter, and urinary spots sodium was 397 milliequivalent per liter.
so your urinary chlorides were actually not matching. In first, you said 130, and uh, the serum chloride, I think, what was can we go to the previous one? The earlier one? The one slide previous?
Hello?
Yeah, the previous slide, one slide previous.
Hello?
Yeah, can we have the previous slide? Yeah,
The
so
ABG, this one or the ABG one, sir?
the serum chloride.
That the ABG one. Yeah, the previous
Okay,
slide.
yes.
No, the I
Yes.
think you showed one more chloride na, after this. What was that? 71?
Hello?
Yeah,
Which
that
slide, sir?
71 was what chloride? It was urine chloride or serum chloride? Next slide, please. Yeah. So here
Yes.
your serum chloride is 76, right?
Yes, sir. 78
So
milliequivalent per liter.
so then how is your venous chloride showing 130? So this is also serum chloride only, and that is also serum chloride. So I think one
Yes,
of the
sir.
readings is not proper. So if you have 76 chloride in the blood, which is basically hypochloremia. So this
Yes,
child
sir.
basically has a hyponatremia, hypokalemia, hypochloremia, and a metabolic alkalosis. So what is this pattern that fits with? It's basically a Bartter syndrome. Fine.
Yes, sir.
Hello. Yeah. And on the top of that, now you have shown urinary chlorides and urinary sodium. Can you go to the next slide?
Yes, sir.
Yeah. So when you have such high urine chloride and high such urine sodium, it basically tells you that there is a salt wasting happening, and that is resulting into low serum sodium and low serum chloride. Fine. So basically, it is a
Yes, sir.
typical condition of a renal salt wasting with alkalosis, and that is a condition of a Bartter syndrome. Fine.
Yes, yes, sir.
Magnesium, yeah. So calcium and magnesium becomes additional testing that you need to do in this condition, because there could be hypomagnesemia and hypercalciuria. Fine, because that is a type of pathology that you find in the renal tubular disease. Okay, can you show
Yes,
the
sir.
next set of slides so then we can go to the discussion about the
Yes, sir.
condition? Yeah,
Yes, sir.
yeah. Go to the next slide, please. Yeah.
These are the serial lab investigations we did. that is
Yeah.
calcium, sodium, potassium, and RFT functions.
So actually, if you see at the creatinine, your creatinine has not risen. Fine, but
Yes,
you're saying that there
yes,
was a drop in the
creatinine
urine
was not.
output. But then how can you explain the drop in the urine output? So was it just a normal urine output or was it actually an oliguria? So unless you quantify, it becomes very difficult to like confirm whether it is actually a normal urine output or actually an oliguria. So you quantification would be very important.
Yes, sir.
Fine. Yeah.
Yes.
So this calcium is a ionic calcium or a what type of calcium is this? Such a low calcium?
Ionic calcium, sir.
Okay. Fine. So it basically tells the same thing: hyponatremia, hypokalemia, hypochloremia, and the normal creatinine, and the normal magnesium, and the blood pressure which was normal. But we have not mentioned what was the exact reading. Fine.
Yes,
Yeah.
yes.
Can please proceed further. Next
All
slide,
these
please.
above.
Yeah. Yeah. Next slide, please.
Hello.
Yeah. Go to the next slide.
Yes, sir. All these above investigations were suggestive of hypokalemic, hypochloremic metabolic alkalosis, along with the renal salt wasting, which was pointing towards the Bartter syndrome. So, endocrinologist opinion was taken considering that, and we started the patient on oral salt and oral potassium supplementation along with the tablet endomethacin, but still electrolyte disturbance was there. So, we have continued with IV 3% NaCl correction. This electrolytemia was persistent even after that corrections. In between, baby got convulsions. We tried to manage, but patient could not be revived.
Anything you have missed in the examination of this child?
Uh, no.
So which type of barter are you suspecting in this? There are multiple types, no, beta? So which type of
Yes,
barter are
sir.
you suspecting?
I think for a postgraduate level, they may not be required to know too much of detail of barter. But I think to conclude and to just give take-home messages, we would like to just highlight few things. So, which would be the symptoms that would tell you that this could be a renal tubular problem? Can you tell us few salient features of renal tubulopathy or renal tubular disorders?
Polyuria can be there, sir.
Yeah, polyuria. Okay. What else?
Failure to thrive can be there in
Okay.
patient.
So failure to thrive is an important symptom. Polyuria. What additional things you should keep in mind?
Along with that, polyuria and failure to thrive, if antenatal history is suggestive of polyhydramnios along with the prematurity, then it will mainly pointing out towards the Bartter syndrome.
Yeah. So Bartter is just one
Also,
type
the
of a yeah. So Bartter is just one type of a tubular disorder. Which are the other tubular disorders that you know of? Which are the different segments that you know of in the kidney, in the tubules?
other syndrome, Gitelman syndrome, is also affecting, which is
Yeah.
affecting the DCT.
Yeah, so to keep it simple, at a postgraduate level, what you need to know is that the renal tubule has got different segments. You have the proximal tubule, you have the distal tubule, in between you have the loop of Henle, that is a thick ascending limb, and the distal nephron and collecting duct. Fine.
Yes,
So
yes, sir.
basically what you need to know is that what are the symptoms, because each segment will have definite characteristic symptoms and then the biochemical findings. So these are the things that you need to identify, and at least you can come to a conclusion that it is a condition which is affecting proximal tubule or a distal tubule or a collecting duct or a loop of Henle, a thick ascending limb. So what would be the features of a proximal tubulopathy or a proximal tubular disorder? What are the functions of a proximal tubule that you know of? So basically tubules are the important part of the kidneys which basically reabsorb all the things that the glomerulus loses. Fine. So whenever you have a glomerular filtration, everything is getting lost at the glomerular level. But if you continue to lose everything, then it would be difficult to maintain normal health. So the tubules are basically the reabsorbing segments. They are basically reabsorbing whatever is getting lost, the excess losses that is trying to minimize the losses. The tubules are the important aspects. Fine. So you have
Yes.
the different parts of the tubule doing different functions. So the important functions of the proximal tubule are, do you know what are the important functions, and hence what could be the signs and symptoms of proximal tubular disorder? So the proximal tubule would reabsorb salt, water, glucose, amino acids, phosphate, bicarbonate. So these are all the things that are getting absorbed in the proximal tubule, and hence whenever you have a proximal tubular disease, what could be the symptoms that you would think of? So it would basically be a proximal renal tubular acidosis. So whenever you have a proximal tubulopathy, it would basically be in the form of metabolic acidosis and a concentration defect. So polyuria, polydipsia, acidosis, they could have some rickets depending on what type of salts are getting lost. So any child who has a failure to thrive, polyuria, polydipsia, acidosis, you would think in terms of a proximal or a distal type of a renal tubular problem. Is that clear? Hello?
Yes, sir. Hello.
Yeah, so are you able to understand? So think of these conditions when you have this kind of a symptom. Next, if it is a loop of Henle, then what are the functions of the loop of Henle?
Sodium and potassium reabsorption from
Yeah.
sodium potassium to chloride co-transporter.
Yeah. So whenever you have this kind of a pathology that is affecting the thick ascending limb of loop of Henle, you are going to have salt wasting that you just saw. Fine. So sodium, potassium, chloride, all these things are getting lost, and you would have acidification defects. Fine.
Yes, sir.
So
Yes,
there
sir.
could be alkalosis, and alkalosis with salt wasting would be a Barter's type of a condition, and a Gitelman which would be in the DCT. Fine. So
Yes, sir.
salt wasting, failure to thrive, alkalosis would be in the thick ascending limb of loop of Henle. And which are the functions of the collecting duct? What is collecting duct mainly concerned about? You spoke about diabetes insipidus, right? So water conservation is main function of the collecting duct.
Yes, sir.
Fine. So whenever you have a polyuria and hypernatremia, free water losses, it's mainly the diabetes insipidus that you're thinking of. And there it could be, if it is a nephrogenic diabetes insipidus where your ADH levels are not making any difference, then it is a collecting duct problem. Fine. So these
Yes,
are
sir.
the broad symptoms that you should think that could be pointing to a tubulopathy. So think of failure to thrive, polyuria, polydipsia, unexplained acidosis, unexplained alkalosis, unexplained anemia, which could also be because of the tubular disease, unexplained rickets, which is not a nutritional rickets. So all these things could be basically pointing to a tubular problem. Fine. And then
Yes, sir.
based on the symptoms that you found, you have to do lab testing, which would be basically in the form of what test broadly you would do. You would do a renal function, that is a BUN creatinine, electrolytes to know what is the sodium, if it is low or high. As you found in your case, hyponatremia, hypokalemia, and a chloride will have to be checked. If it is a
Yes, sir.
acidosis, what is the type of acidosis that you find in a renal tubular acidosis? What type of acidosis do you know of? Do you know what is anion gap?
Normal anion gap metabolic acidosis, sir.
Yeah, so you have to, whenever you find a metabolic acidosis in a child who is suspected to have a tubular problem, you would calculate sodium, potassium, chloride, and bicarb, and sodium minus potassium minus bicarb. If you have this condition, this value between 8 to 12, that would be a normal anion gap, and that is basically associated with hyperchloremia. Your chlorides are high, and as a result, this would basically be a screening test for renal tubular defect, renal tubular acidosis. Fine.
Yes, sir.
So that
Yes,
is
sir.
a anion gap is the first thing that you would do in a child suspected to have a renal tubular acidosis. Fine. Similarly, in
Yes, sir.
metabolic alkalosis, what is the important test that you would do?
In
As
case
you
of
metabolic alkalosis, because
blood
there
pressure,
could,
we can measure, sir, in case of metabolic alkalosis.
yeah. So I think in metabolic alkalosis there are different conditions which you presented. It could be Barter, it could be pseudo Barter like cystic fibrosis, chronic vomiting, it could be chronic laxative abuse, fine, chloride diarrhea. So there could be
Yes, sir.
different conditions. So urinary chloride would be an important test to differentiate these conditions. If it is
Yes,
a
sir.
renal salt wasting and renal chloride wasting, your urinary chloride will be very high, as you found in your case. So that
Yes,
tells
sir.
you that this is a renal chloride wasting, which is in the form
Yes.
of Bartter syndrome. But if your urine chloride is less than 20, then it could be any of the other condition that you mentioned, like cystic fibrosis or chronic vomiting, or any
Yes,
of
sir.
the other conditions like pyloric stenosis, where also you would get metabolic alkalosis. Fine. So
Yes, sir.
so the take home message would be, do anion gap in conditions suspected to have RTA, do urinary chloride in conditions with metabolic alkalosis, and urinary osmolality and serum osmolality would be in situations where you have a polyuria and suspected to have a diabetes insipidus. Fine. So I think at this point you are
Yes, sir.
not expected to have too much information about Barter and how to treat it, but at least the basic principles should be known to you. So in the
Yes, sir.
Bartter syndrome, they basically present with life-threatening dehydration, as you found in your patient. They will have polyuria and all the salt wasting. Fine. So the
Yes, sir.
principles of treatment would be fluid replacement, salt replacement by giving sodium, potassium, bicarbonate, so sodium and potassium correction, and to address the main issue that they have a polyuria basically because of salt wasting, additional medication in the form of indomethacin has to be given, which basically stops all the salt wasting.
Yes, sir.
Is that clear?
Yes, sir.
Yeah. What is the reason why we give indomethacin, and how does it correct the polyuria for Bartter syndrome? What is the pathophysiology behind giving indomethacin?
Endomethacin is a prostaglandin blocker, sir.
Yeah.
If prostaglandin mechanism is it increases the renal blood flow, that will lead to the increase in the urine, that is polyuria. So by blocking the prostaglandin, we can decrease the renal blood flow.
Yeah.
That is why
So
we
that
can
is
give
a
endomethacin.
right. So that is a right answer. So whenever you have a polyuria in this child with salt wasting, it causes volume contraction. So the child has a volume contraction, which causes renin, angiotensin, aldosterone activation, and because of which there is a prostaglandin production which is increased as a maladaptive response to improve the renal blood flow. Fine.
Yes, sir.
So that's the reason why when you have a high prostaglandin, which is often found in Bartter syndrome, they are also responsible for the symptoms of Bartter syndrome in the form of recurrent dehydration, fever, and as a result, to block this abnormal response, you give prostaglandin blockers in the form of indomethacin, or ibuprofen also is also often used. So the
Yes, sir.
treatment of Bartter would be give fluids, correct dehydration, give sodium chloride infusion, correct potassium, and give indomethacin.
Yes,
Fine.
sir.
With this, ideally, one would be able to correct the polyuria and reduce the salt wasting that is happening in this condition with Bartter syndrome. Fine. And
Yes, sir.
usually they also have additional problems in the form of hypercalciuria. And if you do an ultrasound, you would also find a nephrocalcinosis. Fine. So that
Yes,
is a
sir.
usually associated finding. And because of this volume contraction, the main lab parameter that you would find is high renin and aldosterone. So many of these children, when you do renin aldosterone, you would find high renin and high aldosterone. That is reflective of the volume contraction and secondary hyperaldosteronism.
Yes, sir.
Fine, is that clear? So I think this is in a nutshell that you need to know about Bartter syndrome, and many of these children may have acute problems in the initial phase itself and may die because of that if you are not able to treat them properly. Otherwise, if you are able to control the polyuria by giving indomethacin, then most of them will gradually improve their growth, but it is often difficult to control the enormous salt wasting that is happening in this condition. Fine. So Bartter
Yes, sir.
syndrome is basically there is no cure for this condition. You have to just control the symptoms by giving indomethacin and replace all what is getting lost in the urine.
Yes, sir.
Fine.
Yes, sir.
Yeah, sir, madam, would you like to add anything? Because this case was quite difficult at a PG level. More than this, they would be interested to at least know what is the tubular symptoms and how to identify a tubular condition.
Other experts? Bella
Just
madam?
wanted to ask, how would you differentiate between a glomerular and a tubular disease?
In
What are
case
the
of
symptoms of?
glomerular diseases, proteinuria can be there.
Okay, yeah. Anything else that you commonly find? Proteinuria would be on test, like biochemical testing, but something that they may come with grossly.
Edema and hypertension can be there.
Yeah, so right, we are right. Edema, hypertension, red
Hmm.
urine, hematuria, fine, hematuria and proteinuria. So
Yes.
this would be a symptom of a glomerular disease, and tubular disease would be all these symptoms that we just discussed.
And
Fine.
Yes, sir.
and other features like growth failure, anemia
Yeah.
because of low erythropoietin, failure, nephrocalcinosis, all these things are more common in tubular disease as compared to glomerular.
Yes, sir.
Fine. How do you calculate GFR and like what is GFR basically? How do you calculate it? Is there any formula that you know of?
Sorry, sir. Hello.
How do you calculate a GFR in a child with a kidney problem? So just by looking at creatinine, you would not be able to tell what is the renal function. There is something called as a glomerular filtration rate or a eGFR that you calculate bedside that will tell you exactly what is the type of renal function that the child has. Especially in a chronic case, whenever you do a creatinine, you have to calculate a GFR to know whether the child has a suboptimal renal function or a normal renal function. So how do you calculate GFR? What is that formula called? Do you know of Schwartz formula? Have you
Glomerular
heard the term?
filtration. Hello.
Yeah.
Glomerular filtration rate, so we can calculate by the formula that is filtration pressure into filtration coefficient. That we
There is
need
Basically,
a
to
constant, there is something called as
hydrostat.
constant.
no, what you are explaining is a mechanism, the the physiology behind it. So there is a simple formula called as a Schwartz formula, which basically can be calculated whenever you have a creatinine and a height. All that you need is
That
a
is
height in centimeter and
height upon
creatinine.
yes, sir, height upon serum creatinine of the patient, sir.
Okay. Multiplied by, is there anything else to be added or multiplied? So you have to have a height in centimeter multiplied by a constant, which is basically age appropriate constant. So 0.413 is usually taken as the constant for children. And then you divide that by the creatinine in milligram per deciliter. And that will give you the GFR. And it will tell you whether the creatinine and the GFR is normal or if the child has a low GFR, which could be suggestive of a chronic kidney disease. Fine.
Yes, sir.
Yeah. So
Yes,
what is the
sir.
normal GFR that you know of? So 90 to
Normally
120.
20 to 30 in case of newborn, sir. That is neonates.
Yeah. So 90 to 120 would be a normal GFR for a like older child. But as you said rightly, that in a neonate, the GFR has still not like normalized to the normal level, and it is physiologically low. Fine. But
Yes, sir.
you would definitely try to calculate GFR at each visit whenever you do a
Yes, sir.
creatinine,
Yes,
and you
sir.
would try to follow these children. So what are the things that you would see on follow-up in children with tubular problems, and how would you follow them? What are the things to be looked at on follow-up? So you would look at the growth of the child. So what are the parameters that you would see in a growth in any chronic condition? So you would basically,
Weight monitoring
yeah.
we should do, sir.
So height monitoring is more important. Height, weight, head circumference in a child below 3 years would be very, very important because that would tell us whether the growth is proceeding appropriately or not. And if the growth is not proceeding appropriately, then your treatment is probably not adequate. Fine. So you need to
Y-
then take a closer look at the treatment, whether you are properly treating the child or not. So growth will be
Yes, sir.
important.
Yes,
You will
sir.
have to look at the blood pressure of the child at each and every visit, whether the child has a high BP, low BP, normal BP.
Yes,
Fine.
sir.
You
Yes, sir.
would basically look at the intake output charting, the urine output, the type of diet that the child is eating, the development of the child, whether the child is developing normally, because any chronic condition, like any chronic renal disease or any other organ dysfunction which is chronic, will have a effect on the development of a child. So mental development, motor development, social development, all these things definitely would have to be seen at each visit.
Yes, sir.
And to add with this, the biochemical testing in the form of a renal function assessment, creatinine, BUN, EGFR, electrolytes, blood gas, fine. And then in Bartter syndrome, you would also do a calcium creatinine ratio to look for the degree of hypercalciuria, because that is one additional thing that is going to damage the kidneys in the long run. Nephrocalcinosis by doing an urinary ultrasound, the renal ultrasound. So these would be the things that you would basically see on each and every follow-up.
Yes, sir.
Fine. So nutrition
Yes.
becomes very, very important, because unless you feed the child properly, just by giving medicines and just by doing few tests, you would not be able to improve the growth of the child. So nutrition, like proper attention to the calories and the protein, fat intake would be also very, very important. Fine, because these children who
Yes, sir.
have polyuria and salt wasting, they will basically not be thriving well, because most of their energy is getting wasted in just trying to replace the water intake. So the fluid intake would be the major thing that they would be doing. So their calorie intake is definitely compromised. So you have to take additional efforts in building up calories for these children. So diet
Yes, sir.
becomes very, very important and should not be neglected.
Yes, sir.
And as we said, that any child who has any kidney disease, even if it is an acute, may have a risk for progressing to chronic kidney disease in the long run. So in this child, basically, it was a unfortunate event that the child did not survive. But in any child where you are dealing with a chronic illness, you have to keep a close watch on the long-term renal function, because they can silently go into chronic kidney disease and may land into end-stage renal disease. um, how do you categorize the degree of chronic kidney disease that you know of? Different stages of chronic kidney disease. Are you aware of how do you categorize them into different stages?
Rifle criteria.
Rightful
That is
and
more for acute renal
That is for
failure.
acute kidney injury. Yes,
Yeah.
sir.
So for chronic
age
kidney
group.
injury, how do you calculate different stages of CKD? So you have to basically first calculate the GFR, that is height in centimeter into 0.413 divided by serum creatinine. You will get a value of GFR. For suppose if it is 90, then any kidney disease which is there since 3 months, even with a normal GFR, you would label it as a CKD stage 1. Fine. And then
Yes, sir.
depending on the further drop in the GFR, you would basically then, if it is 60 to 90, it would be like stage 2. Below 60, it would be like a further worsening stage of chronic kidney disease. And when you are below 15, it is basically an advanced or end stage kidney disease. Fine. So
Yes,
at this
sir.
point of time, you are most likely going into need for dialysis or a kidney transplantation. So whenever there is a progressive, any chronic kidney disease, in the long term, the GFR is going to progressively drop, and hence all your efforts should be towards retarding the progression of a chronic kidney disease. So, which are the things that you would keep in mind so as to prevent the retardation of chronic kidney disease into worsening kidney dysfunction? So, simple measures that you can practice in any chronic kidney disease condition. So, first would be to avoid any nephrotoxic insults. Fine. So, don't give any ibugesic or NSAIDs or any nephrotoxic antibiotics. Second would be control hypertension if the child develops hypertension. Restrict salt intake. So, excess salt would be putting pressure on the already suffering kidney. Adequate prompt treatment of any infection if the child develops any UTI or any infection, that has to be treated properly, and close attention to the nutrition. So these would be the supportive measures that you would take so as to prevent further worsening of the already compromised kidney function.
Yes, sir.
Fine. So I think majorly these are the points that you need to know. Is there anything else that anybody would want to add? Manish sir, you would like to conclude anything, or like conclude the
No,
case and the discussion?
I think it is uh, the complete picture has been cleared, sir.
Okay.
Excuse me, did I miss the clinical photographs by any chance? I thought she had some photographs. Okay, here.
Yes, ma'am.
So this is pre and post dehydration, or what do these two photographs signify?
First photo is at admission, ma'am, and second photo after intubation, that is later.
No, but that is not showing us anything related to, like, sorry, I must have missed it in between also, but like a pre-dehydration, post-dehydration,
No, ma'am,
any
that
such photographs?
no, ma'am, we don't have that photograph.
Looking at
Pre-dehydration,
the
we don't have.
dyselectrolemia, I'm just asking you. Dehydration
It's
and dyselectrolemia.
after correction only, ma'am. This photo.
Because I just want to share, I have a pseudobatters many years ago, which Dr. Abhishek Kulkarni actually helped me in diagnosing genetically. And I had the pre and post photograph of that patient, which are very helpful in teaching or discussing or whatever you say when you are, doing it on a webinar where the actual patient is not in front of us. So I would really request students, if they can keep such clinically relevant photographs for, the PG cases, it will be helpful for everyone to learn. That's
Yes,
all I
ma'am.
have to say. Yeah,
Yeah,
thank
because
Yes,
you.
ma'am.
as Madam rightly said, even Barter will have some typical syndromic faces. So, what faces that is usually reported are triangular faces, prominent eyes, the protruding ears. Fine. So, these are the typical faces. If you have seen one case of Barter, then you would remember it for life. That such typical faces would be, kind of a uh, like a spot diagnosis. So, whenever you have such cases, you should try to show the pictures as well. Fine.
Yes, sir.
And any syndromes with ambiguous genitalia would be definitely important. Fine. So I think
Otherwise, it was
Yes,
an
sir.
excellent case presentation and excellently discussed by the experts. Thank you so much
thank
for
you,
this,
ma'am.
episode. Thank you.
Thank you.
Coming to the formal end of the Thanksgiving gratitude expressing session, as Madam rightly said, excellent discussion with a strong emphasis on pathophysiology, clinical, management correlation. I'm sure it was not only a learning experience for the PG students, but it was truly refreshing and enriching for all of us. All the great work was done. Whatever we used to learn from anatomy, physiology, still we are correlating it. I sincerely thank our extreme experts for sharing their valuable time, insights, guiding us through the finer nuances of pediatric renal care in spite of having been so late. My appreciation to all the entire scientific team, convener Dr. Bela Verma Madam, my coordinators, my uh, other experts, advisors, and the entire MAHAIP team for arranging such a great PG forum, which has been always a good teaching experience for everyone. My appreciation to Dr. Supriya for her case presentation and to her mentor as well for guiding her through this. Thank you,
Thank you,
Pallavi
ma'am.
ma'am, for your constant support as a technical team. Today's discussion reinforces that clinical excellence is built through dialogue, reflection, and continuous learning. Thank you all the pediatricians, postgraduate residents who joined us online and have contributed to this vibrant academic exchange. I express apology if I have mistaken to take anybody's name for gratitude mentioning. Thank you all again. We look forward to your presence in our next MAHAIP PG Case Forum sessions. Thank you one and all again. Thank you. Good night.
Thank you, Madhavi, ma'am. Thank you.
Thank
Thank you,
you.
Thank
Good
ma'am.
you.
night. Good night,
Good
Sati
night.
sir.
Good night.
Good night.